Hello, everyone. I'd like to welcome everyone to the first ever Brain Conference. It's coming to you, or I'm speaking to you live from London. I don't know if you can tell, but it's a typical London day here, covered in fog, cold, but very beautiful still. I think the first thing that we should do is there's lots of thank yous and a little bit of housekeeping to do. So if we just pop up a slide now. And essentially, the beginning, I would like to say thanks to all of the faculty and all of the speakers for giving their time to not only to present today, but for preparation and all of the emailing and all of the communication prior to this point. Each session today, after it's finished, there'll be a short interval before the next session goes live. So you have a few minutes to make a quick cup of tea, etc., etc. Throughout the conference, there'll be an opportunity to ask questions. And I'd like to remind people to try and use the Q&A box that's on the right of the live stream feed to submit your questions. Please feel free to share your thoughts on the conference using the hashtag as demonstrated. The talks will all be available on demand after each day. So if any of your colleagues have not been able to join us today, they can still register throughout the time of the conference and view the on-demand content. We wouldn't also be here if we didn't have the help of the wonderful sponsors that are listed. So it'd be really nice of you if you could maybe go and check out some of their home pages. Some great kit is coming onto the scene, as we all well know, and it'd be nice if we could just look at some of that stuff. And just a general thank you again for everyone that's attending, for all of the sponsors, all of the faculty, and just a really big thank you. It's been a really, really, really hard year. So for attending, I'm very grateful, and for helping, I'm also very grateful. So with that said, I think it's time to go to our first speaker, Dr. Mani Putharan, a friend of mine who operates up in Liverpool in the United Kingdom. And he's going to be talking first about MCA bifurcation aneurysms and their endovascular treatment.
Thank you, Paul, for organizing this fantastic lecture series. So I would like to talk about endovascular treatment of MCA aneurysms. So I work at the Walton Center, and we've got a team of 4 interventionists. So we did an audit of our work, and from 2008 to 2018, we have done just over 500 MCA aneurysms. And there were some interesting stats in this. The first thing was half of them were elective treatment. So we were doing about 50 MCAs a year. In acute treatment, what we found was that whether you use a balloon, or obviously you don't use stents, but if you use a balloon or bare catheter coiling, there was not much difference about the occlusion grade at the time of treatment. So it is between 65 to 75%. Whereas in elective aneurysm treatment, we found a significant difference. So stent-assisted and balloon-assisted coiling, you can achieve greater than 90% occlusion rate. Why I say greater than 90%, this audit was actually done by my surgical colleagues to take care of, so that we don't have the bias. They unfortunately included web in stent-assisted coiling. So a couple of webs we had recurrence. So if you take that, it's greater than 90% occlusion. Unfortunately, bare coiling, it was quite shocking that this technique of double catheter or single catheter, it was averaging about 60% occlusion at the time of treatment. And the retreatment rate, so we had grade 2 recurrences, which we left alone, but grade 3, there's greater than 20% retreatment rate for these group. And interestingly, people have this kind of notion that they use balloons and stents, your complication rate goes up. And there was no significant difference. Both were around 2 to 3% significant complication. I'm not talking about groin hematomas, but major stroke or death. So I'll start off with some complications, few cases. So MCA aneurysms, as you know, when you're treating this, you have a surgical option. So you have to always consider that before treating these patients and whether you can minimize the risk. So I've first case, a 48-year-old female patient with a family history of subarachnoid hemorrhage. Her sister was treated electively, but mother had a subarachnoid hemorrhage and was treated in the same hospital. So this is a typical wide neck aneurysm, and in my practice, I usually put 2 balloons for these. So 2 balloons inflated. But the important thing is the tip, the wire tips. And a lot of times, you lose concentration when you're coiling. And on the right of the screen, you can see the tip of the catheter has moved now to one side. And I didn't notice that. And probably it must be when I was inflating or repositioning the catheter. I mean, it looks very obvious now, but at the time I didn't notice the fact that this wire had gone to a branch vessel. So you can see that no extravasation, everything looks fine, no surge in BP. And remember, there will not be any surge in BP for these tiny bleeds. I did a CT, there was a bleed. Luckily, nothing happened to the patient. I mean, usually 2 days post-op is our post-elective management, but this patient stayed for a week and a half. Luckily, I mean, it didn't progress because these patients are on dual antiplatelets. So the key here is for me is when I do these injections, treatments, I do very little runs. But in the end, when I do the run, I always have it in the venous phase to look for contrast extravasation. And the important thing, again, this is something that was told to me by a senior colleague, was perform a CT head before the stent placement, not after, because if there is bleed, you can always not put a stent and then stop the dual antiplatelets. Then the usual stuff, a wire position you need to check. If you're using dual lumen balloons, remember you don't need a wire. But this is a key, perform a CT before stent placement. The next one I would like to do is a sad story. A 32-year-old nurse came 10 years ago. She had a subarachnoid hemorrhage, very in a poor state. I treated with bare coiling, one of the MCA, but next to it there was a wide neck aneurysm. And at that time I said, acutely it's impossible to treat this. So offered clipping, and she didn't want to. She survived the first bleed, came out of it, recovered. She went back to nursing, wanted to start a family. And every time we see her in the clinic, she says, can you treat this aneurysm? And I kind of brushed it aside saying no. Unfortunately, and it was offered for surgical clipping also. She didn't want that. Finally, she wrote an email to the to the trust saying that she would like to go ahead and she's happy to take the risk. And I decided to treat with, again, this is a mistake. I should have used a straight a silk and deployed a silk. Instead, I decided to put a Leo and coil over the Leo, which was, on hindsight, quite a stupid decision. So first catheter for the Leo is there, and I put this 90-degree echelon. The echelon catheter was here. There was no wire. I pulled it back so that it flops into the aneurysm. All it did was, as you know, the echelon catheter is braided, so it has got a lot of torque. And it torqued into the aneurysm. And that's what happened. Suddenly, the bleed. I had to immediately put a balloon in, and the patient went for surgery and clipping. And the last complication I want to show, again, this is quite important for trainees who are doing this, is that you need to look at delayed run. So this is acutely, this patient had clot evacuation and MC aneurysm coiling, came back for a recurrence, and look at the wire. So I was putting a double balloon in, and the wire was somewhere here at some stage. And I didn't notice that. When I did the delayed run, you can see there's contrast extravasation there. Very small amount, but that is a hemorrhage. And here you can rescue this patient. You can just coil that vessel because it's non-dominant hemisphere. It's not a very eloquent area. It's not a motor strip, so you can do that. I didn't do that. Waited for 4 hours for the surgeon to operate. By the time, huge hematoma. So let's look at some kind of what you call successful cases rather than complications. So acute aneurysm treatment, the standard practice is bare coiling. Unfortunately, I was struggling to look for cases because all my cases I put coils, so I was quite surprised to that. So I found this case, poor grade subarachnoid hemorrhage. This patient, I mean, I don't see a justification for putting a balloon because it's a narrow neck. Some of you might say, why not put a web? Anyway, I put coils and occluded it. Patient is a poor grade, so let the patient recover and then decide. Most of my cases, I would say, is single balloon. So again, aneurysm, MC aneurysm, you might wonder why is this wire sticking out? It shouldn't be there. So that's an aneurysm, MCA, a lobulated aneurysm. So balloon assisted coiling. So I've changed to dual lumen. Since the Eclipse 12 has come, most of the cases I just use a dual lumen balloon because it's trackable, and I find it more trackable than the single lumen balloon. I don't know whether others have the same experience. And the fact is you don't need to put a wire. You can always take the wire out for safety. Acute subarachnoid hemorrhage, double balloon, yes. At least in UK, people frown about this. I did my first one in 2009, and then there was a gap of 2 years where I didn't do because I got a lot of stick in my hospital for doing all these fancy stuff. But I came up with this plan to stick with this all the time. So 5,000 units of heparin is given a groin puncture for all my cases, unless I forget. The key I found was keeping the blood pressure high. So it's close to 100 mean, systolic about 130 to 140. I try to achieve that before even getting catheters up. I use a 7 French Fabuki nowadays, so it gives you a lot of options, especially with Eclipse 2L. So with the 7 French Fabuki, you can use Eclipse 2L and a single lumen Eclipse, or Eclipse 2L and Scepter, but you can't use 2 dual lumen Eclipse balloons. They don't work, So the combinations, you have to be careful. So this is a classical example of MCA aneurysm wide neck, and you can see the vessels have gone into spasm. This is post-subarachnoid hemorrhage. So 2 balloons. And this is what I try to tell trainees also, but most of them wouldn't do this, is the difficult part is actually getting the balloons. But once the balloons are in position, it's very quick to coil, quicker than if you're just using no balloon and trying to coil, forming a framing basket and things like that. So once you form the balloon position, that's it, you coil, and you can see the vessels are in spasm. So the new device is the web device, which has definitely changed acute subarachnoid hemorrhage treatment. This is a poor grade, again, intubated patient. When they lightened the sedation, she was flexing. So we decided to treat this aneurysm. So web, it's very quick. So on a CT angiogram, you can measure and be ready with the size. 20 minutes to half an hour, you can treat a standard aneurysm. And that's all you need. You're not looking for perfection. If there's a recurrence, you can always treat it later. So you've got stasis, and that is satisfactory occlusion. Unfortunately, the patient didn't make up, had a stay in the hospital for about 2 to 3 weeks and then passed away. Now, elective aneurysm treatment, that's a totally different ballgame. So in these patients, in our hospital practice is for 7 days, they are loaded on aspirin and clopidogrel. They come to the hospital, get a check of their, what do you call that, the aspirin level with this Verify Now. If there is resistance to clopidogrel, we change the patient to ticagrelor. So once there is some activity with these platelet inhibition, then we proceed for treatment. Again, all my patients, first thing I do is get the mean to about 100. So I'll show you some standard cases. So this is an aneurysm, very standard aneurysm, wide neck aneurysm. Most people probably would just put coils. So I use a balloon, again, dual lumen balloon inflate and coil, and that is satisfactory. And I would agree if people say that I should have left it at this, not proceed, but I do put stents in a lot of these cases, braided stents. So you can see that's an S0 with a middle marker. It's very visible, and that middle marker is a brilliant idea. And in small vessels, you can easily deploy it. So what about MCA aneurysm coiling and stenting? What are the challenges, and why is 2 balloons better than 1? There are a lot of reasons. So people think that when you use 2 balloons, it's more complicated. I disagree with that. Initially, yes, there is always a fear factor, but once you get over that, it's not a big issue, especially with the newer balloons. So that's a wide-necked MCA aneurysm. And say you put a catheter into the aneurysm to coil, and what happens usually is the catheter, whether it's the direction of the parent vessel, the anatomy, tries to compartmentalize. It's very difficult to centralize the catheter. So what you decide is, okay, you put 1 balloon. So you put 1 balloon, the catheter definitely gets pushed to one side. And what again you have is compartmentalization. Then you can't get that even distribution of coils, then always a chance the coil loop can come out. So you decide to use 2 balloons. And this is what I used to do in the beginning, 2 balloons in this position. And always the problem is once you inflate 1 balloon and then you try to inflate the other, there's always an interaction. And which is, for some reason, it's a reverse. So when you inflate one, the other moves the opposite way. And it's quite difficult to do that. So what I've decided for the last 5 years is this. I use a bigger balloon, then take a smaller balloon, slightly inflate, but pull back while I fully inflate. And that kind of corks it. And the advantage of this is the fact that the catheter centralizes. And it's very easy then to adjust. So if you want a catheter to move one side, you inflate one balloon more and deflate the other, and you can adjust that, And then you get a dense packing, then you can decide which one you want to stent. In this case, I stented the lower branch with, again, an S0. Okay, again, what are the challenges in coiling with two balloons? So one of the things people try to do is they try to park the balloon in the easier branch, and that's the one thing I've changed in my practice. I always try to catheterize that more difficult branch. And initially, it was quite difficult. Before the dual balloons came, we had to shape the echelon like a pigtail, hook it in one branch, take wire pass, then exchange with the 300 wire. Over that, you put a balloon, and it was just difficult, very stressful. I hated the exchange technique because of the risk of always wire perforation distally. So since this dual lumen balloons came, it is just godsend, and they are very soft and trackable. So now once it's in position, you can just inflate the balloon and pull it and straighten this. You can do another thing also is that you don't have to inflate the balloon. If you're worried, you can put a stent, partially deploy the stent, and then straighten the catheter. So once it's in position, that's a difficult bit. Then it's straightforward. You decide which side you want to put a stent. So this aneurysm is protruding to one side more. So I decide to stent that side. So two balloons, coils, and end of it, you put a balloon. Again, the biggest advantage of using a dual lumen balloon is end of it, you can just push the catheter, balloon into the stent and remodel. I do that almost now consistently, this remodeling of the thing. Now, warning, I just need to be to junior colleagues or trainees that this is, you have to be careful. This is a ruptured ACOM aneurysm. I'm just showing it for an example. I wouldn't take a balloon through this ACOM, especially with this bulge. If it prolapses there, that is risky. So in these cases, a technique you can use is I just couldn't get a catheter into this. So what I did, I put a Traxxas wire there, like a buttress, and then took the balloon catheter. So the balloon catheter with a 07 wire, and you can track it along the other wire, and it is much more easy. So you can do different techniques. Now, MC aneurysm retreatment, this is where I think dual lumen balloon is, or using two balloons is extremely important. And why is that when you have recurrence, you can't really size the aneurysm, and it's always shallow, especially if you have recurrence with a web device. It ends to be a very shallow recurrence. So you need to inflate two balloons. And inflating two balloons is not just for coil prolapse, but it's to know the anatomy. So I do very little runs, especially if you have two balloons inflated, you can't do runs. But I move the machine a lot. So I operate the machine, I move it a lot during my procedure. So the balloon gives me the anatomical landmark. So two balloons and coils. Oh, in this case, what happened was that this balloon actually deflated. There was a technical issue with this Eclipse balloon. So what I did was I partially deployed a stent and used it like a balloon. So pushed it against the coil, continued coiling, and end of it, you can. So this I use sometimes, where instead of using two balloons, you can use a partially deployed stent and a balloon. So that's the result, and you get good opposition. So that's a shorter Leo, the 2 by 12, and that's a longer. It's a longer because of this 5 complete struts. So that's a 25 length, and this is a 12 length because it has got 2 complete struts. And this is something I've never done, but I saw this in a picture where people have gone through the braided stent and put it like this. I've never done this, so this is another option people could try. The new device, which I've also used often, is the Comaneci device, and that's very good for treatment. And the advantage of Comaneci is there's no flow arrest. So if you use 2 balloons, yes, you're worried about, you need to be quick in how you do things. But with the Comaneci, if you put it on the parent vessel, in the larger one, so from M1 to M2, that vessel remains patent, and you can put the shorter balloon in the other branch. And the good thing about the Comaneci is that I usually put it through a headway, so you can, end of it, you can have the option of putting through a Leo or a Zero or any of the stents Evo. So end of it, I put a stent, and partly it's because there's a small coil loop that came out, so just to hold it in position. This is the last case in the series I would like to show, is a patient who had a left MCS pseudoaneurysm. So he was an 8-year-old lad who was on a school trip and fell off a cliff and had a massive head injury. So he was at a sister hospital, the pediatric hospital. There we use a Philips machine, so you'll see all the angios are slightly different now. So this child had a pseudoaneurysm. It was spotted on the first scan in 2016, but we kind of ignored because he was in a pretty bad state. But he then improved. He's gone back to school. He needs some special care in school, but otherwise he leads independent life. So he's now 13 or 14 years old. And then when we scanned, it's got bigger. So I've asked the opinion of a lot of people, including Professor Chapeau and a couple of surgeons abroad, to get an idea what to do about this. And the reason is all the branches are coming around from it. And these are all eloquent branches, dominant hemisphere. We did an occlusion test with balloon in the M1 and also distally, and there was no collaterals or very delayed collaterals. So just to show you the poor collaterals, very delayed collateralization. So we decided to protect this. And I have to say, thanks to Dr. Chandran, who insisted on this. I actually wanted to occlude the distal vessel with coils and then protect the two branches, but he gave this idea and it worked quite well. So we put an EVO across and used it like a balloon. And a balloon was placed in the lower branch, inflated. So the EVO stent was never deployed till it was completely occluded. So aneurysm was stented, coiled, densely coiled, and then the EVO was deployed. Unfortunately, the first EVO came right to the edge, so I had to telescope it with the second EVO stent. The result was fine. The patient woke up fine. That was the most important thing. And that's angiogram post stenting. So obviously, this was done only 3 months ago, so we need to wait for the long-term result. The reason why I was not very keen to put a stent through the aneurysm and I wanted to occlude distally was I thought that will probably guarantee a better occlusion if you can occlude the aneurysm and the distal branch and then stent the proximal two vessels. Thank you very much.
Lovely. Thanks, Mani. That was a really interesting talk. Some great cases, actually, and lots of learning points there. I think there's a couple of questions come through. So the first one, which guiding catheter do you use when using two balloons and coiling simultaneously?
I use Fabuki, 7 French Fabuki. So as I said, we have an option of using Eclipse 2L and a Scepter dual lumen balloon, but you cannot use with the 7 French, you cannot use 2 Scepter dual lumen. That's a disadvantage of it. But you can use 2 Scepters, but not 2 Eclipse dual lumen balloons.
Okay. So you can use 2 Scepter XCs through the 7 French Fabuki?
Yes. So it's, I don't know, the profile must be smaller than an Eclipse, or because of the Eclipse, it's slightly different, the shape of the Eclipse, cross-sectional shape, probably because of that.
Yeah, I tend to use Scepter XCs. So when I don't really do double balloon modeling for wide-necked MCAs, we still tend to send them for clipping, to be honest, although that might change. There's another question come in. In your experience, do you think the Eclipse or Scepter is more trackable for difficult M2 navigation? Any tips in positioning of the balloons in the M1?
So that is one thing I found was that I don't know what is the mechanical properties of this, but this dual lumen Eclipse balloon tracks probably the best in my hands. So I've had cases where I've tried. Recently, we had some problems with the manufacturing. There was shortage of Eclipse, and I decided to use more and more of Scepter. But even you can actually shape the tip of the Scepter. There's a technique which Rene showed me. Even without putting that shape, trackability is not as good as the Eclipse dual lumen, but most of the time you can get away with it.
Okay. One last question. I noticed in your acute ruptured cases, you showed several cases where you've got MCA, M2 branch and distal spasm. In those cases, do you ever, would you treat the spasm first, either with chemical or mechanical angioplasty, so that it makes navigation of the balloon easier? And also as you're testing, as you're probing with the wire and things, you're less likely to worsen the spasm or rupture. Is that something you routinely use or do?
Yes, I started using that more and more often. So if it is M1 and M2, yes, I've even done it with Communici device. I put in a Communici and try to open it. I've used balloons to open it, definitely. But the ones I showed was quite about it. I just wake up the patient, see if there's a problem. Triple H therapy. That's
okay. Last question. instead of the Comaneci device, could we use stent retrievers?
Probably yes. Yeah, you can actually use it. I've not tried that, but instead of that, the best thing is to partially deploy a stent. So take a long stent and partially deploy it, and you can use it as a balloon. You know? So,
yeah, and then finish by just deploying the stent.
Yeah, just deploying that stent.
Yeah. Okay. Lovely. All right. Thanks. That's great, Manny. Manny will be staying with us now to give his second talk, which is actually very nicely follows on from the first one. Which is on braided stent design, overviews and differences.
Thank you, Paul. So the next talk is about braided stents and the design overview. So I'm not going to talk about the the engineering side of it. I'm going to talk more on my experience. So as you know, EVO is a new one, so I don't have much experience. So when I've used it, I've felt certain things about certain of these, and I'll highlight those points. So as you all know, Leo was the first to come. I think it came in 2008 or 9, and it's a brilliant technological achievement to 10 years ago come up with a brilliant stent ladders. Then came this Elvis Jr., which I've used 3 or 4 times. I didn't like it, to be honest. But I'll tell you the reason why I used it in a particular case. Then came the Aneurysm, again, a brilliant design. And the fact was that to have this middle marker, I don't know how people think about it. For me, I thought that was very clever. It really helps in positioning. A lot of times, when you're positioning, you don't know how much of foreshortening or where the proximal part of the stent ends, and this really helps. Then came EVO, which is another brilliant design, very, very easy to use. And I'll highlight a few cases on that. So I just wanted to remind you that young lad, the reason why I used an EVO rather than Leo or Aneurysm is, first of all, in that size, EVO had the longest length. That in that particular size, it goes up to 33. So that is the first thing. Then for some reason, this is my experience, I feel Leo is the softest. And I felt if you're putting one stent, EVO, I thought would hold the construct better. In my experience, it doesn't foreshorten as much as the Leo. So this is a technical, this spec I got from a company website. So this radio opacity is true, but all of them actually have 16 wires, even the Leo. But unfortunately, Leo only 2 wires you can see, and that has issues when you're when I'm teaching registrars. They struggle with that to understand. I've used now over 150 Leos. I still love using it because I'm used to that device and how it behaves. Now, talking about micro catheter compatibility, this is not true from the website I took. I mean, it's a company website, but it's not right. So EVO, it's right. It goes through a headway 17 and a scepter. Aneurysm actually goes through a scepter without any problem. I've never had any problem. But it also goes through an eclipse. But mind you, you can have problems. Okay. Occasionally, I've got eclipse, scepter stuck in, not scepter, the Aneurysm stuck in an eclipse. Now, Leo is the best in compatibility. Any catheter, I prefer using an echelon 10, but it'll go through headway SL10, and it goes through both eclipse and scepter C without any problems. And the last thing, I again don't agree. In my practice, I don't agree that the EVO has a lot of foreshortening. Leo definitely has foreshortening, shortens a lot, but not the EVO in my experience. So baby Leo stent, like I said, it's got 2 longitudinal radiopaque markers, and it's resheathable up to 90%. All of these stents are resheathable. Compatible with the 017 catheter, but a wide range of catheters, 017 catheters. And it's suitable up to a vessel diameter from 1.5 up onwards. Now, this is quite important. Leo stent is only one that is marked starting from 2 millimeters. So the smallest one is marked at the 2 millimeter diameter. The other 2 are from 2.5, but they say it will go down to a 1.5. So I think it's a bit of marketing. Now, the catheter I prefer to use on a Leo is echelon 10. And the reason is that when I first started using Leo stent, we didn't have dual lumen balloons. And sometimes it's very tricky to get into branch vessels. And I found this echelon is very good. You can shape it like a pigtail, and you can torque it into branches, turn it, catheterize better, and then with this you can deploy the LEO. And one of the advantages of deploying a LEO through an echelon rather than a headway or SL10 is the one-to-one feedback. You get less of a jump when you deploy if you use an echelon. But nowadays with the dual lumen balloon, it's much better. One of the negative things I found about the LEO is this, the wing. So there is a metal wing at the proximal aspect of it, and the stent wires loop around it. So if it's a straight, like a M1 where you are deploying it, if it's a straight landing zone or proximal part, it deploys fine. But in an acute angle, one of these struts can get stuck, and then you might run into problems. Now, coming to S0 stent, it's a nitinol stent compatible with 1017 catheters. And the company says headway, use headway. And I rightly think that is the best catheter for this. I've had issues when I've used it with an echelon catheter. I think one of the problems with the echelon is if you coil, if you put three coils, it changes. There is some ovalization inside. And then if you use that same catheter to put a stent, the stent can get stuck. And they talk about this blue oxide surface coating. I'm not sure all these patients get dual antiplatelets. I wouldn't make any difference to that, in my practice. And the compatibility, as I said, headway 17 is the best. Scepter balloon and Eclipse, you have to be careful. Sometimes you can have issues. And this is just to show the middle marker and how the ends are. Now, EVO, this is where I have the least experience, but the practice is used to use a 17 headway catheter. And I've tried to push it through an Eclipse 12, and it won't even enter the hub. So scepter balloon is what you need to use. And this is a little bit of technical jargon in this. So these are the series. Now we have close to reached, actually, if you take the whole of our center cases, we have close to 200 LEO cases we have done. So comparing all these, I personally feel LEO is best deployed by an echelon 10 Eclipse dual lumen balloon. The second choice for me will be the Scepter C balloon. And S0 and EVO is best deployed through a headway or a Scepter balloon. So early experience, I just want to touch on this. I'm quite convinced. I've never used a flow diverter in MCA bifurcation. I've used one in an M2 fusiform aneurysm. I've used a flow diverter, silk, baby silk, but not in bifurcation. So I always stick with braided stents. So one of the early cases, the first case I did was in 2009, and that was relatively easy cases. So this is one of the most challenging cases I did in the beginning. That was in 2011. So a 45-year-old chap, he actually had a bleed 2 weeks before, and he came to the hospital with a large MCA, and the decision, nobody wanted to coil this. It looks nasty, and the surgeon didn't want to clip. He was quite obese. That was the other thing, it was more. So he came back 3 months later. 44-year-old chap, and I decided to treat him electively. And when I look back, I think the stress must have been quite high treating, because our old machine, visibility is very poor. So the position was to put 2 stents and coil. And here you can see in the old machine, you can hardly see the LEO. So if I was doing a lot more of this, sure, the complication rate would have been really high. So it's good that I was quite choosy at that time. And now when we have the Siemens machine, it's much, much easier. This patient, that's a 5-year follow-up. We actually have a 7-year follow-up. And unfortunately, 2 months ago, he passed away from COVID-related complications. And I want to just show this, the early stent. This is the Elvis Junior, yeah. That has come microvention, the early braided stent. I've just done 2 or 3 cases, and I don't like this stent. It doesn't conform to the vessel wall. But in this case, we decided to use it. So it's an SCA aneurysm with the SCA coming from there. And you have this posteriorly, you have a perforator coming off. So you have to protect that. Just to show you the perforator from the back. Yeah, so what we decided was to use this Elvis Junior. Today, definitely I would have used a EVO or a 0 here in this, or LEO. So we protected SCA with a laser cut stent. Don't ask me why. At that time, we thought that was the best choice. 2 catheters in the aneurysm and densely packed. And this is again to register, as I always reiterate, when you look at aneurysm balloon-assisted coiling, it's not the straight-on view that is important. You need to look at the barrel view here. So you can see the barrel view. If you're putting a balloon, you need to see the coils around it. And you can see the perforator still patent. And the reason why I used then, we decided to use this Elvis Junior was we thought, it has got wider struts. So hopefully the perforator would be patent. But today I wouldn't worry about putting any other braided stent here. So you can see that in the perforator is patent. Now coming up to some other aneurysms which we treat recently or in the last 7-8 years. So the first choice for me has always been Leo. And since now Asiro and Evo has come, we've started using them evenly. So this is a ACOM aneurysm in a patient with a hypoplastic left A1. So again, this dual lumen balloons is a game changer for these. So you track through the aneurysm, you can track the dual lumen balloon into the branch, inflate it, straighten it. I decided to not treat with the balloon inflated, rather I put a stent partially, because I felt if I inflate the balloon, it might, with this very odd angle, it might collapse into aneurysm. So used a stent as a that just the 3D, and that's the end result. And you can see the follow-up, this hypoplastic A1 has increased in size, compensated. Now, important things about braided stents when compared to laser cut stent. I don't think it's a problem now because the trainees now are more used to using braided stents. But when we changed from laser cut to braided stent, there was a good learning curve, because braided laser cut, you just have to unsheath and it opens. But braided stents, you have to work with it, So one of the things is so-called kneeing or shoulder effect, where you have to, if you just unsheath it, it will not open. So you have to, when you come here, you have to push it, apply forward force with the catheter to get this bending. So this kind of kneeing effect. And then, so you can see that it is kneed forward and covered the whole thing. And you can put a balloon and just inflate and remodel it. So in complex aneurysms, again, Leo is very good because of its compatibility with Eclipse dual lumen balloon. So this is a patient doesn't have an A1 on one side, so both have to be protected. So initially, I actually got the patient in to get a few runs to see if I can get a projection. And this is a projection we thought was the best, So the plan was to put a longer stent on one side and the shorter one, and decided to coil and completely pack. Again, you can see this longer stent, I've used it like a balloon where I've not deployed it, and deployed it only after finishing the case. And that's the post-treatment angiogram. Now, other thing about Eclipse balloon is what I found is the stability. It's much better stability in a dual lumen Eclipse rather than a single lumen. Scepter is also good, but Scepter, like I said, it doesn't come to the smaller sizes. So Eclipse dual lumen balloon starts at 7. I think the Scepter starts at 10. And so in a PCOM aneurysm, so here it looks quite straightforward, the PCOM origin, but here you can see it is a sharp angle. And that's a recurrence on a previously treated PCOM post-subarachnoid hemorrhage. So I know a lot of people would say flow divert, and as I said, in my practice, I tend to use very occasionally flow diverters, and only for certain specific reasons. So in my practice, this is what I like to do is put a mini, the smallest of the Leos, and then coil the aneurysm. So again, use a dual lumen balloon. I've not fully inflated the dual lumen balloon, enough to just coil. And then end of it, I've deployed the stent. And this is what I'm saying. I'm always conscious when you come to the end of the Leo, whether it gets stuck, So you can see as it comes, that is where that detachment zone is. And in this case, it is open, but sometimes you struggle. So you can see the edge, that's the edge of the stent, and it's covered the aneurysm. So that's pre-treatment, the recurrence, and you've covered it. So it's completely occluded. Asiro, you can do the same thing, but the biggest advantage of Asiro, I find, is that long introduction wire, the wire that sticks out at the end of the Asiro, but otherwise it's just a brilliant stent. You can precisely positioned because it has got less foreshortening. So how I deploy a Leo is that if I deploy the smallest Leo, the 12 millimeter length Leo, I know if 1/2 and 1 full helix comes out, I know that is half the stent. So I know another half is to go. So I count the helix. So in a 18 Leo, you have got about 3, or sometimes you see 4 helix, and in the larger one there is always 5 complete helix. So when half of that comes out, I know that's how it is. Whereas for S0, it's good because you just have to look at the middle marker. So I'll show you some cases. So this is a 44-year-old female who came with sudden severe headache and vomiting while on holiday. She never had a CT scan there. So 3 weeks later, she comes back to Liverpool, and we find this small aneurysm. And what do you do with this? We decide to treat. So preloaded her overnight, and then decide to treat. So again, stent, and you can see the middle marker. So when you're positioning it, it's very easy. As soon as you come here, then you can judge. You can double it, and you can judge where it'll land. But this is a disadvantage. Look at the length of that distal wire it's poking out. And I hope the company changes that. So that's the actual tip of the stent, just to hold the coils in place. And about conformability to vessel wall, it does conform very well. And in bends, it's easy to deploy compared to Leo because you can see the whole of the stent. So just to show you a case here, ACOM aneurysm, so bilateral planned stenting. So this you can see, you can easily deploy. And you can see it's suddenly bulged here. It's a little bit of pressure. So other side, standard practice. So when I do ACOMs, I leave one side balloon. I only deploy one side first, because if the catheter comes up, you can always go through the side where the balloon is inflated. So on that side, I put the stent in the end. Unfortunately, I had a complication with this. This is the first time I've had this where I've dissected the vessel by overinflating. Now, this is important. When you inflate the balloon, this is a marker, distal marker of the balloon. And I always try to bulge it a bit more, but you can see here it's bulged more, not here. So I don't know what happened here, but this is probably overinflated. So when I did a run, there was a small dissection. Again, patient did not have any consequences, but I didn't put a stent after this on this side. Would it have made a difference because patient had to be on aspirin and clopidogrel because a stent has already been placed on the other side? But I decided to be cautious and brought her back another day for a stent. So now talking about conformation to small vessel, this is where I have a problem with S0 and the fact that it has got that long wire. So small aneurysm in a patient who already had a left MC aneurysm coil from a previous subarachnoid hemorrhage. So the plan was to stent there and another stent and occlude that. So I catheterized that, the small upper branch with, in this case, I've said aneurysm coiled, S0 deployed by an echelon. So this is an early state when S0 first came, and then I was told by the company to use headway. So here, I thought, what's happening here? Is it not open? But on the lateral view, so that's the middle marker. So this position is here. And here it looks, it's open, but it didn't give me a lot of confidence. I was a bit worried, So a coiled end of it, I put a Leo. So this is a time when I realized that S0 can have problem with dual lumen balloon. So I had a dual lumen balloon and I tried to put an S0 and it didn't work. So I had to put a Leo for this. Otherwise, there's no reason why I should not put a S0 here. It would work fine. So today, if I'm doing a similar case, I would do it the other way. So this is a case of a 43-year-old male patient, previous subarachnoid hemorrhage. Sadly, this left MC aneurysm was recoiled 4 times. And this is, if any surgeons are listening to this, they'll be slagging me off, So our policy now in our hospital for the last, I think, 5-6 years is that first recurrence, if you can't do it, it goes for clipping. If you can do it, then you have to have some kind of guarantee of giving a complete occlusion. That's why we use stents. So in this case, again, the shorter vessel, I use a smaller length balloon. And so here you can see the smaller length balloon and the bigger balloon in the larger vessel, coil aneurysm, and then end of it deploy the Leo. Again, this is where I want to show you that marker wing getting, it gets stuck in this. And you can see I'm playing with it, pushing. It takes a while. And finally, it releases. It's always stressful in these angles. So this is what I'm saying, the combination. So in this case, I wouldn't put an Evo or an S0. So always in the small, these kind of branches, I would put a Leo. And the other thing you need to know is when you deploy LEO, you always have to move the machine to make sure these markers are separate, because in some projections, you might think the markers are overlapping like here, but in this case, obviously, I turned around to make sure it's working. And exactly a similar case, the one I showed you before was on the right side. So this is on the left side. A patient had a small PCOM aneurysm treated post-subarachnoid hemorrhage. And this was a tiny bulge at that time. 3 years later, every time we monitor, it goes by 1 millimeter. And we think, oh, it is usual statement we say is what we call inter-reporter variance and things like that. But when you look from 3 years ago, there was a sudden significant increase. And he was a young chap, so we decided to treat that. Now here it looks as though this vessel is coming straight from the MCA, but that's not the case. So that's the branch, that's aneurysm, that's the parent vessel. So the branch is actually coming like that into that. So you have to, you have to protect it, put a stent like a C. And this is a technique I learned from René. So I put a catheter on the top one and a balloon in the lower one to protect. And the balloon is also, when you're deploying the stent, you need to have protection. Sometimes the catheter can just jump forward. And this is a technique learned from Professor Chapeau, watching him do that. So in this case, you deploy the LEO, and then now you have to turn the LEO forward. So again, first you need to get rid of the marker. So that's the fixation, bringing it stuck onto this. So you have to twist it a few times. And this, like I said, is always stressful. And you don't have this problem with Assuro or Evo. Yes, so now it's the fixation ring has come out. So now you push the catheter into the aneurysm, and now you have to twist it. So you applied forward force. You apply this forward force. And probably I should have inflated the balloon a little bit to have more control. Yeah, you keep pushing it forward, and then it will finally open up, completely. There. So now the stent is opened. So that's how I've coiled it. And here it's, this is why I'm saying you need that AP view is not the right view. Here it looks as though the stent is inside the parent vessel and the coil is here, but you can see the parent vessel, that's the edge of the parent vessel here. Yeah, and this is what I was saying, the vessel actually comes like that and goes this way, and that's the coil. So there. So the vessel actually coils this way, and this coil is being jammed in the by the stent. And actually, funnily enough, I was able to get the angiogram, follow-up angiogram 1 year. It was last week, so I've just put it onto the slide. So this is the immediate post-op, and this is the follow-up angiogram. So it's occluded, and I'll show you the spin. So that's the lateral view. And the spin, you can see, so here it looks as though the coil is out, but a little bit is out, but not too much. But here it looks as though it's in the parent vessel, but let's wait for the spin to, yes. So you can see the parent vessel is here, and you can see it's like an inverted C. So that stent is protected, and that's a branch coming off. Assuro versus LEO. Why I would use an Assuro over a LEO? I had problems with LEO, especially in this thing called the S curve. So when you have a curve like this, it's very difficult to put a LEO, because in the second curve, the first part of the curve is easy. Second part, it's very difficult to know how it's opened up. So here you can see, I just want to show junior colleagues about this. Is what I found these days is to catheterize with a J wire. It's brilliant. The hybrid 0708 J wire is probably the safest. A lot of times I use that. So you can see it. I found it very difficult to catheterize. I had to use a balloon here to buttress and take it. So this was a difficult case. So I deployed the Assuro on one side, and just for time's sake, I'll just show it. So Assuro is deployed on one side, and the next side, I had to use a LEO. And to catheterize that again, I had to use a balloon here. So this was just a nightmare case, And this is the last thing you want. And because you don't have a lot of support, each time I pushed it, it's prolapsing here. The first one opens, and the second one, it's always difficult. So the second one, you can see, you don't know what's happening here. And this is the end result I got. And because you've got a lot of coil mass, even if you move the machine, you don't know for sure whether it's open. I couldn't catheterize it back because, like I said, it was hairpin bending into the M1. So I assume it's open because the follow-up looks fine. But this is where, if you have an Evo or an Assuro, you'll see, because you can see the whole of the stent. Lastly, just to talk about Evo stent, this is a new kid on the block, and it's a very good stent, very easy to deploy, and a very similar case to the other one I showed. So in this case, I decided not to use LEO. decided to use a combination of an S0 and an EVO. So you can see that. So decided to put an EVO in that fashion and a S0 on the other side. So this is just to show you, this is not a straight curve. This actually curves on itself and comes down. So again, just to show you the limitation of this technique when you use an EVO is that you can't use an Eclipse 2L. So to catheterize, you have to use a catheter to go through the aneurysm. So this is a disadvantage also, whereas other one, you can just inflate the balloon and straighten it. So in this, what I do is I put the catheter, in this case, headway. I'll just push it forward. So push it there. And then you have to use the stent. So stent goes through this, and you have to partially deploy the stent to straighten the curve. You can try, sometimes it works, but most of the time it doesn't. So again, I'll just forward it a bit. So you can see the stent is being deployed, and then once it's deployed, you pull, it anchors, it straightens, then you pull back the stent and deploy. So the stent is being deployed. So here, there was some bony landmarks over it, and I was quite certain the stent is opened. And like I said, I moved the machine myself, so I always am moving to see different projections. And to my surprise, it had kinked there. So I don't know whether this is slightly more softer, but it was easy to correct it. All I had to do, resheath it, and then just be a little bit more careful in this bend. So on the other side, I used a balloon, and like I said, in ACOMs, I use one balloon on one side always till I completely pack the aneurysm. And end of it, I put a S0, and this is open because I've checked it, and this wraps around itself. The last case I have to show you is EVO in a recurrent MC aneurysm. This is just a nightmare. The first attempt, we couldn't get past this because all the coils were looped around this vessel, and this coil was around it. And the surgeon also felt if there were so many coils in the neck, they might not be able to occlude it. So finally, I studied the first angiogram and realized there is a ring through which you can get your balloon. So using a lot of projection, we have managed to catheterize both. So through the loops of it. So here I've got a scepter, and here I've got an Eclipse. And this is what I'm saying. I feel Eclipse would have inflated much more uniformly. You can see the scepter. It was not, inflating all that uniformly. So end of it, I put a Leo in the low one, and then Evo on the top one. So this bit I couldn't see because of the coils collapsing. So this point here is actually here. So I thought, okay, this is fine. This is opened up and shouldn't be a problem. Everything looks fine. So here you can see it's pinched, apparently pinched, but here you can see it's opened up on the other projection. We do a run. This is after 15 minutes, and these are stressful cases. This was only done last week, and the patient is still last Thursday we did it. We had to give ticagrelol, TPA, IV TPA loading dose. And then 3 hours, I tried to push a catheter through this, wire through this, and finally managed to open the vessel. And the patient is fine, but it was quite nervous. So discussion, lastly, Leo baby, the advantage is mainly Eclipse. It's a fantastic combination. And also it's a very good stent. And if you're used to it, you still find it's one of the best stents to use. S0 is easier to deploy, and the middle marker makes it a brilliant idea to position it properly. And with EVO, both of them, you have that visibility of the vessel contour. And I don't agree with the fact that EVO does not foreshorten my experience compared to a Leo. So thank you very much. Thank you.
Thanks, Manny. Another great talk. Actually, you've got some really good cases there. So we've got a few questions. So just to begin with, do you flow divert above the circle of Willis or prefer to use braided stents?
Yeah, I'm paranoid about flow diverters, because I feel in aneurysm, so even in IC aneurysms, I coil, cavernous aneurysm, I coil and don't put flow diverters barely, because it's like a door. In an aneurysm, you put a flow diverter, it's closed. So definitely not in a bifurcation. MCA, ACOM. ACOM might be on one side. I put a flow. I think I've done one case where I put a flow diverter on one side because if there's a recurrence, you can go from the other side and coil. So I'm paranoid about that. So no, I truly believe in these braided stents, and that's what I stick with.
Okay. Another question, what's your typical antiplatelet regime? We'll have more talks about antiplatelets and things later, but what's your typical regime, and for how long?
Yes, so for us, 7 days of preloading aspirin clopidogrel, and we check the levels prior with Verify Now. I'm not an expert in these things. I just follow what the radiographers, the results they give me. Post-treatment, dual antiplatelets for 6 months, and then we stop clopidogrel, continue aspirin for 18 more months. So altogether 2 years of aspirin.
Okay, and then you completely stop the aspirin.
Yes, right. Yes.
And have you noticed any complications, like delayed complications from stopping aspirin at 2 years?
So one thing I found is that, so this patient last week I treated, I know that if you get away for the first 48 hours or few days without a complication, usually it stays patent. I've had complications. A patient had a TIA 1.5 months after the procedure. There were 2 patients who had complete occlusion of the stent. One patient went into kind of a depression, suicidal thoughts, and for 2 weeks he stopped his aspirin clopidogrel and the MCA completely occluded. Similar case with another patient who had. So now I'm very careful. Patients who are chronic smokers, I'm careful. Then the mental health. So those are things, to have good results, you have to be careful about those things also.
Yeah, so good patient selection, basically, you mean?
Selection is important. Compliance is so important.
Yeah, completely agree. And I think the other thing is Professor Henkes reported a good case of loss of aspirin functionality secondary to taking ibuprofen at the same time. So there's quite a lot of drug interactions as well that can occur. And I think one of the other things that is not fully understood is people can lose their sensitivity to aspirin secondary to other things. So trauma, for example, if you look up trauma, people can be sensitive to aspirin. They can have a major trauma, or they can have a cardiac event, for example. They stop becoming responsive to aspirin, and then 6-7 weeks later, they become responsive to aspirin again.
Paul, please stop it. I'm getting scared now.
Sorry. Okay, the next one. Do you try to compress the braided stents to aid flow diversion? And if so, which stents do you think confer this advantage?
All of them you can compress, but not for flow diversion. Basically, as I showed you, the kneeing effect is to spread the stent across the neck of that. That's the main reason. I don't think of that as a flow diversion. And the other thing I need to say is that you have to pack densely. So the ones I've had recurrence or remnant filling is this one where I've not packed it tightly. And there was this concept years ago in meetings, people used to say, once you put a vice, then you don't have to pack it that tightly. I don't agree with that. So I try to pack it as much as I can. Yeah,
so I would agree with you. I think if you're going to use laser cut stents, which will alter the inflow angles, then you still need to pack, but then you've essentially altered the anatomy quite a lot potentially, and it will continue to alter over time. Whereas my experience with braided stents, which is obviously not as good as or as extensive as yours, but the angles don't really change because they don't have that sort of longitudinal force to change. So if you're going to treat an aneurysm there, you do need to pack it quite tightly, which leads me on to another question. I mean, where do you think that the Trellex coil will sit in your sort of practice for these sorts of aneurysms? Because the advantage of that is you can kind of see through the coil. So it will be easy for you to see your stent deployment, your stent positioning, but we don't have any long-term follow-up on those.
I've not used it, so I can't explain about that. But one of the things I use more now is these hydrogel coils. I don't know if it matters, but subconsciously I feel, if you pack with that, it might occlude better.
Might occlude better, yeah. Okay. I think we know the answer to this, that you've shown some cases here. Do you half T stenting or positioning when half T stenting?
Yeah, so half T, like I said, I've never done this so-called Y stenting where both of them come into the M1, so I always half T. And positioning, like I said, my experience with this is mainly for the Leo. And the Leo, the shorter one, in my mind, that's how I work. The shortest Leo has got 2 full helix, and in the edge it has got 2 half helix. So in my mind, I think, okay, half, so 1 half and 1 full comes, I know that's the midway. Then I position it and then predict where it lands, and it works for me. So
yeah,
so that's how I do it.
Do you ever use sort of intraoperatively? Do you, I mean, with your newer machine with the Siemens, intraoperatively and prior to coiling, like stent runs, so 3-dimensional rotational stent runs?
No.
Is
So
that something
all
that
my sorry, no, I don't do any of those, so I showed you one case in an ACOM where I did, but that was just for getting a good picture. So all my coiling now I do in a particular protocol called this stent deploy. It's a very grainy, and the visibility is very good. And I don't do much runs, so I coil negative roadmap, so there's no roadmap, because I move the machine all the time to different projections. So I use a balloon as a landmark, for anatomical landmark, and just coil and do some.
Okay, great. I think there's one last question. Please give some tips to deploy braided stents. Do you push the microcatheter after it is half deployed to open it completely?
Yes, definitely. So that forward force has to be the right when you begin with braided stents. As soon as you deploy, so you deploy a little bit, and then you pull back to this correct position where you want the distal part to land. So there's a good technique Professor Chapeau taught me, was that first to make big movements, when you pull back, you just have to pull the whole system back, that the catheter and the stent. When you want to make micro adjustments, like 1 millimeter of that fine adjustment, what you do is you pretend as though you're resheathing the stent. So you're pushing forward with the catheter, but pulling back with the stent wire. And then you can get these micro movements. But in the end, when you're actually deploying, you have to have this forward force with the catheter so that it really opposes. That is a key, I think. The forward tension should be there.
Yeah, no, so it's pretty much the same as what I do, and I think what my colleagues down in London do as well. Okay, I think that's everything, Manny. That's thanks a lot. Those are a couple of really great, really interesting talks there on the basics of stent design, aneurysm, particularly MCA bifurcation aneurysm. Certainly in England, we still have, as you kind of alluded to, routine controversies with the neurosurgeons about whether or not we should treat those or not. I don't think that's such a problem in other places around the world, but in the UK, it's a continual headache for us.
And just I have to say, thank you so much to everybody whom I learned, especially from Rene. He has been fantastic in teaching all of this. So thank you.
Lovely. All right. Thanks, Manny. Next up, we have our newest colleague down in London, Mohammed Agour. He will be talking about stent design and choice.
Great. Hello, everyone. Thank you so much, Paul, for the kind invitation. And as you said, I just joined the Royal London Hospital a few weeks ago, and I'm very happy, guys, to join all of you. Here's the dream team in alphabetical order. Paul with the nice Christmas tree and a nice invitation. Joe and Levan is just in the room, I guess, next door, and Ken is somewhere today. So somewhere. Anyway, so today I'll be talking about stent design and choice. I don't have actually a lot of cases. It's more or less some technical or how the stents are designed, and this I believe will help us to choose better stents or the good stent for the good indication. So I have no conflict of interest for this talk. I try to put most of the stents on the market, so we have an idea about most of the stents. So actually, how do we choose a stent today in our angio suites or in our departments? Well, one of the reasons can be that we are used to some stents, and not all of them. Others, like we are participating in a register or a study, or it depends on the stock and sizes we have. Or we try every case to change partners and types of stent, or we have some certain affinity, whatever it is, with some company. Anyway, the the stent choice actually must be done depending on these points. For sure, we can consider others like the one we saw before, but these are the main ones. The first is the anatomy, the aneurysm location, the neck of the aneurysm, how it is and how it is presenting, the technique that we will deploy the stent, or how we are thinking of treating the patient. And one of the main, or for me it is the main point actually, is the how the stent is designed and how it will behave for each treatment and for each case and patient. So to understand this more, we must have an idea about the stent materials. We can have stainless steel, nitinol, or cobalt alloys, or some mixture of these materials. The stainless steel is corrosion resistant. It handles very well the deformation, and it is very stable, but at the same time, it is a little bit allergic and has low elasticity, and it's not very well compatible with MRI. The nitinol is one of the most used materials for stents intracranially and others peripherally in the body. It has a capacity to keep its memory, and it is super elastic, and it can go inside a small microcatheter without permanent deformation, and it can then regain its shape when it is deployed. Some drawbacks are the elasticity. It can be an advantage and a disadvantage, and it has a low radio opacity, but this is we can easily deal with this thing. The cobalt alloys, they have excellent radial force, and they are highly corrosion resistant, and they are MR compatible. Anyway, for the understanding how the stent are designed and manufactured, we have to classify them first. So we have two major classifications depending on the process of the stent design itself. Sorry for the spelling mistakes here, process. So we have the laser cut stent and the braided stents, or we can classify them also into types depending on their types or how we will use them. So we can have them, if it is regarding the coating, we can classify them into bare and coated. For the functional use, whether simple stents for coiling or for diverters or for treatment of stenosis, we need higher radial force. Or depending on the material, we can have metal or biodegradable stents. So the laser cut stents, as this depending on the design and manufacture, we have the laser cut and braided. So the laser cut stents, we all know how it is done. It is done actually by a laser beam, which will cut onto a metal tube. This is the basic thing about how we manufacture the laser cut stents. We have a lot of laser cut stents on the market. We have the Clino, the Solitaire, the Neuroform Atlas, the Enterprise. The laser cut also, we can give shapes very easily to stent, like for the barrel, for example. And it's a waste that Medtronic stopped manufacturing this device. It was very interesting device and concept for bifurcation aneurysm with wide neck. We can also do some new devices like the Eclipse, which is, instead of doing horizontal stenting, we can use the Eclipse to cover the neck of the aneurysm, and then we can pass through it and coil the aneurysm itself. We use also the laser to manufacture the neck bridging devices like the Pulse Rider, the Piconos, and the Trispan. If you go back to the first stent which was made, actually the first laser cut stent was in the US in 1994, and the YAG laser was the early laser source for this. The idea is that the laser will go and melt the stent material, and then the cut metal will be blown away. This process actually was not very fine, and there was like significant dross, slag, and oxide layers, and a lot of back wall damage. Then came the fiber laser, which was more reliable with excellent beam, but it also caused some dross and back wall damage. Then short pulse lasers were developed, like the nano, pico, and femtosecond pulse range lasers. And these lasers actually will not melt the metal. It will vaporize the metal and it will produce much less damage for the stent itself and much lower heat load. And then a simple idea which came, and it was at the same time a revolutionary one, that the wet cutting is, the idea is simple, is to use some jet of water actually to decrease the temperature load, so the surface metal is not damaged, as we can see on these images. To go a little bit more into the stents, and we have to talk all this the same language to go further. So we have to know what is the apex, the segment of stent, the connector which connects the cells, the cell itself. All of these are the components of the stent that we use and see. So we are now still talking about the laser cut stents. The stent design, we can have the open cell stents and closed cell stents. I'm starting really from the basic things. So the open cell stents, we have the cells that they are not all connected together with connectors. The closed cell stents, all the cells are connected from the four sides of the cell to adjacent cells. We can have several shapes like helical, sequential, individual rings, and the connectors also can vary. Where we will put the connector itself, which will connect different cells together. So we can have like here a peak-to-peak connector. Here we will place the connector between the two cells. This will not affect very much the profile of stent, means that we can pass it always through small microcatheters, and this will limit actually the foreshortening. We can also connect or put the connectors between two cells from peak to valley, and this will increase a little bit the profile of stent, so we will need bigger microcatheters, but we will not have any foreshortening. Or we can put the connectors between the struts, connecting the struts from mid to mid strut, and this will also increase the profile, and the foreshortening will be mild. Connectors also have a very important role, that they affect actually the stent flexibility. If we have more connectors between the cells, the stent will be much more rigid. And if we have less connectors between the cells, the stent will be much more flexible, and we can navigate it easily anywhere. Also, the connectors, if we use the same number of connectors, if we have more space between the connectors, the stent will be much more flexible. If we have less space between the connectors, the stent will be rigid. So this is enters actually in the concept on design of each stent, what we want to do with it exactly, and sometimes we manage to do many different things on the same stent, like edges and the center and things like this. And this is the example actually of the neuroform. The first neuroform, the neuroform 1, we had only one connectors between the cells, and this actually led that the stent can bulge a little bit into the aneurysm if we have a wide neck aneurysm. Then there was this evolution for the neuroform 2, where we added another connector, and then the neuroform 3, which had 3 connectors in the middle and 2 connectors on each side of the stent. And this improved actually the sculpting, especially in front of the aneurysmal wall. But at the same time, unfortunately, it reduced a little bit the conformability of the stent against the arterial wall. That was the first 2 versions, but actually the third version with the 3 connectors worked on this problem, and we can see here the 3 connectors in the middle of the stent, in front or facing the aneurysmal neck, will give some support to the mass of coils and will prevent the stent from bulging inside the aneurysmal sac itself. And the 2 distal ends with less connectors, we will have more flexibility, so we can navigate the stent easily. This is, I believe, one of the most important things to know about open cell and closed cell laser cut stent when we are choosing a stent. We used to work for many years with Neuroform and Enterprise stents. They had a big share of them for some years, and we had always the choice between both of them. But actually, to summarize this, if we have an acute angle, or we are treating, for example, an aneurysm which on a bifurcation, and the artery will have an important angle, so it is better to use an open cell laser cut stent, because if we use an closed cell laser cut stent, actually it will bend in the middle here, and we cannot see this on the fluoroscopy. We will just put the stent, we will do a control, and we will find that we have a problem, like a thrombus or something with the flow, and we don't see it actually, and we will not really understand what is the problem. So if you have any important angle, we have to use the open cell laser cut stent. I will try to go a little bit faster because for the sake of time. This is about the trackability and conformability. We talked about this, about the open cell stents. So actually the open cell stents, we can push them easily in the microcatheters. They take the shape of the artery, and they are on the arterial wall, but they bulge a little bit inside the aneurysm itself. The closed cells is the opposite. We have good scaffolding. We can resheath these stents, but we will have less apposition to the walls of the vessels. In this case, we better use an open cell stent, or use the closed cell but a longer one, so we can work it a little bit on the walls. The issue of conformability actually is very important. We think that this is something trivial or doesn't exist a lot, but actually in this study we found it like it is around 20% of cases. Another point also to keep in mind, that whenever we use a balloon or a stent, or we do anything other than inside the aneurysmal sac, we have this risk of changing the anatomy. So whenever we are using a balloon or putting a stent, it is better at the end of the procedure for sure to keep the wire inside when we pull everything distal to the stent, or wherever we use the balloon, and then we do a control and we verify that everything is fine. So to compare, to summarize this regarding the open cells and closed cells, the open cells, some cells are connected, some not. Each segment move independently. This enhances anchoring, promotes stent opening, and in laser cut stents in general, we don't have a foreshortening. The closed cells, they are less conformable to aneurysmal wall, and they increase coverage on the wall of the vessel. And as I said, we use longer stent to deploy ends in straight segments for the closed ones. And for sure, this is basic. The open cell stent, we cannot recapture them. The closed cell, for sure, we can. In general, the advantage of laser cut stent, whether open cell or closed cells, they are stable, there are no foreshortening, and they are much easier to deploy. I will try to run now because I see that I have 6 minutes left, Paul, or even less. So the braided stents, it's easy that we go from the with the filament, we do winding on a jig, and then we heat it, and then we polish it, and then we have the braided stents. We can have woven, welded, knitted, or coil. We can have open end or closed end. And what summarize everything about the braided stents, that we call them the sliding cell stent or the moving stents. The wires are not attached together, so whatever you do, like push or pull or change size or whatever, the wires move one over the other. One of the most important thing for the braided stents are the braiding angle. It affects porosity, and if we see in this example that if we take all the parameters the same and we just change this small angle between the wires, the porosity will change. It also affects the resistance and flexibility of the stent. If we take, for example, the Leo and the Leo Plus, the only thing which was done to improve the stent actually was just the braiding angle from 45 degrees to 60 degrees, and we gained 30% of radial force, improved the deployment, and the flared, and also avoided the tulip effects. The radial force is the constant expansion force of the stents. It should not be too high, not to create a vessel trauma. And for this example, if we are given a nominal diameter of like a 3.5 millimeters, and if we put the stent in an arterial lumen which is less than the nominal diameter, we will have higher radial force, and vice versa. If we put a 3.5 millimeter stent in a vessel more than its nominal diameter, we will have a small radial force. The nitinol had the advantage that the radial force varies according to temperature. At 37 degrees, the force is multiplied by 2, and it is stent expansion is with low pressure, and this reduces the trauma on the arterial wall itself. If we compare the braided and laser cut stents, and radial force is higher in laser cut stents, the vessel wall percent coverage is also higher. Is higher in braided stents. And there is another study which compared also laser cut and braided stents. We found that we have more metal coverage in braided stents, and braided stents shortens much more. We don't have this with laser cut stent, and they have higher pore densities. To go further, I will talk about the flow diverters for the coming 2-3 minutes. The same, we have to talk about porosity and pore density. The porosity is the void or the empty space in the material itself, and is a fraction of the volume, and it's always a percentage. The pore density is the number of holes or pores we have in a given area. If we take this example, they all have 50% porosity, but they have various pore densities. As an example for this, the layo and the silk, actually the silk is like 3 layers, and the porosity of 70% and the minimum pore density of 18 pores per millimeter square is reported to be the ideal porosity for aneurysm. This is interesting to know when we are treating, we're putting the stent in a curve. If we take this ophthalmic aneurysm, we will see that the pore density will be exactly not the same, but it will be more if we have the aneurysm in this location. If we have a side wall aneurysm, the pore density will not differ whatever stent size of stent we are using. Instead of the concavity here, when we will see that the pore density is much more, and this aneurysm will actually thrombose faster than others, because we have the pore density is higher here. If we have an aneurysm which the same in the convexity, or like this ophthalmic, if we take a 4 millimeter stent to put it in the same nominal, the same size of the artery, there will be no difference of the percentage of area coverage. But if we take a stent of 5 millimeters, we will put it in a 4 millimeters artery, it will cover more the neck. And if we put a 5 millimeter stent in a small artery, it will cover much more the neck of the aneurysm. So nominal size, if we put it in the same artery, there will be no much change. So sometimes if we want to make more flow diversion, we have to take a bigger nominal diameter of stent to put it in artery. It's not the case actually on the if we have an aneurysm in the concavity, in the inner aspect. The best percentage of area coverage, the highest one, is to use the same size of the vessel itself. So a 4 millimeter stent in a 4 millimeter artery. If it's the aneurysm is on the side wall, there will be no difference. Whatever size you use, it will not be of any difference. We'll jump very fast for the sizing of flow diverters. It is a key factor. It is very important to size very well the flow diverters, and this can cause a lot of problems if you don't have a proper sizing. we all had the situations where there is a stent which is not open or displaced or a very strange stent, and we think what we can do. We do just an angioplasty to open the stent or put another stent here. Sizing is very important, and we now have a lot of software to help us in doing this. And now I use shorter flow diverters and even smaller ones than before. Softwares which are available also, they can calculate the surface metal coverage. I guess the time is over, Paul.
I think what we can do is, if you want to talk about metal stents versus biodegradable stents, we'll have to. I think probably the audience would be very interested to hear your thoughts on this. So why don't we stick to this and give you a couple of extra minutes, Mohammed.
Okay, thank you so much. Actually, I will. The rest is very fast. It's about the metal stent and biodegradable stents, and this, I believe, is the future for the stents in general. The advantage of metal stents is we know it already. We studied it. We studied the stents. We are using it. We see it also. This is very important. But the drawbacks, we all know that we have a foreign body, a metal, ischemic complication, thrombosis, antiplatelets, hemorrhage, danger in pediatric population, or if patients who have allergy for metals. The biodegradable stents, they have potential advantages regarding the thromboembolic complications, and probably will not be using a double antiplatelets, but the drawbacks that there is this inflammatory response which might cause stenosis, maybe also thrombosis. The biodegradation process can deform the stent. We can have some fragments distally, and we don't know yet, and we have to study more its effect on tiny perforators. So this is a recent study in 2019 where about 48 poly-L-lactic acid wires were used to create a biodegradable stent. It was implanted in 36 rabbit aneurysm models, and when they tested the in vitro degradation, they showed that the biodegradation will take around 1.5 years, and in vivo, the aneurysm occlusion rate were, we have to know this, 0 when we put the stent, and for about 1 month, and 20% at 3 months, and 50% at 6 months. Interestingly, at 1 year, it came below again to 33%. And so this is important to study, and to know also that the device fragmentation was not observed in any lesions. And this is the stent as we can see, and we can see here the 2 gold markers on the extremities of stents. The stents in the market, we all know them. I will not go a lot of them, but we have the recent one, the Pipeline Flex. The recent version of the Pipeline had the CE mark 2015. It has a synthetic layer as a metal covering. The studies showed that the thromboembolic events did not vary very much with the previous device, but there are a lot of studies going on about using a single antiplatelet therapy. The Surpass stent from Stryker, it was a very good stent, and the first version, and when we put it, the aneurysm thrombosis very fast, but it was a little bit hard to push up. With the Surpass Evolve, the new version is easily to be pushed up. The Fred, it's like 2 stents one another, you know, with the Fred Junior. I guess I took much more time than I was allowed, Paul, so I don't want to disturb you.
It's all right, Mohammed. I think I'm going to have to ask you to stop there, though.
Yeah, I am.
Other people are going to talk.
Thank you so much.
Diverters. But that was really interesting. Just one quick question: Do you vary your antiplatelet regime based on whether you implant a braided stent, or not a flow diverter, but a braided stent versus an open cell or a closed cell laser cut stent? Do you alter it at all?
Yeah, thank you for raising the question, because actually in our specialty, as we all know, we don't have any, as we talked recently, we don't have any rules about heparin we injected or not, how much, the quantity for antiplatelet therapy. It varies from country to country, center to center, operator to operator, even in the same center. I used the same double antiplatelet therapy for all stents. braided laser cut flow diverters, and I've been using this since years, and I had no problem with this. Plavix, the regular thing, and double antiplatelet for 3 months. Only the Plavix for 3 months, and I put aspirin 300 milligrams for 1 year, and I stop it after. It's not for lifetime, and the double antiplatelets is only 3 months, not 6 months, and I don't test it.
Okay.
Like the cardiologist, but and everything actually is going fine. I deploy the stent very slowly. I wait a few minutes. If there's a problem, I can manage with other drugs, but usually it's when it goes well.
All right, lovely. Thank you very much, Mohammed. I'll hopefully see you at work shortly.
Yeah, thank
you. All right, thanks, Mohammed.
Yeah, bye.
Okay. So time for our next talk by anyone that follows the Neuroaddicts group will know very well the amazing cases that Professor Kubilay Adan shows, sometimes completely extensive knowledge. And it's just great hearing his inputs on different treatment options. He's going to be talking about double stenting and stent plus balloon techniques for complicated bifurcation aneurysms. This is a pre-recorded talk, but he will hopefully join for a Q&A session afterwards. So please, if there are any questions, just put them in the Q&A box. Thank you.
Hi, good morning. I hope everybody are well and healthy, and please accept our warmest greetings from Istanbul. Today, it will be a pleasure for me to share our experience about double stent coiling procedures for the treatment of complex bifurcation aneurysm. Let me share my desktop with you. And as all of you know, endovascular treatment of complex bifurcation aneurysms remains to be a challenge for us. Since the introductions of neuro-dedicated stents, we use these stents to protect the parent arteries during the coiling of white neck aneurysms. However, during the coiling of some bifurcation aneurysms, deployment of a single stent may not be sufficient to protect all side branches. And double stenting procedures have been described to treat those aneurysms. Various double stenting techniques configuration have been described, such as X, T, parallel, or Y stenting. And very recently, stent plus balloon-assisted coiling technique has been defined to treat complex bifurcation aneurysm. Y stenting is the first described double stenting technique, and today, despite the development of neck bridging and flow diverter devices, Y stenting remains the eligible endovascular method of treatment for complex bifurcation aneurysms. At our department, nowadays we use low-profile open cell stents, Neuroform Atlas stents, to perform Y stenting. However, we have much experience also about braided stents to perform Y stenting. And very recently, we decided to review our data to analyze the outcomes of cases treated with Y stenting using 2 braided stents. And we included 40 aneurysms to the study, and the mean follow-up period was about 2 years. We observed a quite high complete occlusion rate follow-up. About 85% of the aneurysms were completely occluded at the last follow-up angio, and no patient needed retreatment. However, we also observed relatively high rate of thromboembolic complications, although majority of them did not cause any symptom or morbidity. Most common complication using the braided stents was intraoperative in-stent thrombus formation. Let me share some cases treated with braided stent. This case was a complex MCA aneurysm, which was treated with 2 braided stents deployed in Y configuration. Another ACOM aneurysm with a white neck, 2 Leo stents were deployed in Y configuration and the 6-month follow-up angio shows the stable occlusion of the aneurysm and a mild instant stenosis. This case was referred to us after a failed surgery. We first decided to coil the aneurysm. We deployed a single stent into the upper branch. However, during the coiling, some coils tend to protrude into the lower branch, so we deployed a second level stent into the lower trunk, and we coiled the aneurysm. At the end of the procedure, we noticed a small thrombus formation inside the stent, and we give a low dose intra-arterial agrestat infusion, and the thrombus resolved completely. The patient neurologically intact, evoked neurologically intact. Another patient with carotid bifurcation aneurysm, which was treated with 2 braided stents deployed in Y configuration, and the intraprocedural control angio showed a small thrombus formation just at the neck region, and a low dose intra-arterial agrestat infusion through the stent delivery catheter completely resolved the thrombus formation. Intraprocedural thrombus formation is a frequent but usually asymptomatic complication of Y stenting while using 2 braided stents. And unless a technical complication, another technical complication coexists, instant thrombus formation usually respond very well to intra-arterial agrestat anti-aggregan infusions. Another important point with the braid stent in Y stenting, targeting a pre-procedural platelet inhibition level between 60 to 19% may very much help to decrease the incidence of intraprocedural thromboembolic complications. And now at the last 5 years, we have started to use low-profile open cell stents for Y stenting. We use Neuroform Atlas stents. And very recently, we analyzed our data to investigate the midterm results of our cases. We included 30 aneurysms, and we observed that Atlas stents with Y stenting achieves a quite high aneurysm occlusion rate with a low complication rate. Therefore, at the moment, we prefer Neuroform Atlas stents to perform Y stenting procedures at our department. Some cases treated with Atlas stents, an MCA aneurysm, 2 stents, Neuroform stent deployed in Y configuration, and the aneurysm was coiled then after. A small MCA aneurysm, 2 Atlas stent deployed in Y configuration, and the 1-year follow-up angio shows the stable occlusion of the aneurysm. A wide-neck ECOM aneurysm, 2 Atlas stents are deployed nicely into the anterior cerebral arteries. Another MCA aneurysm with a difficult neck morphology, both MCA trunks were arising with very acute angles from the neck, but we could safely deploy 2 Neuroform stents into the MCA trunks, and the aneurysm was coiled safely. Another MCA aneurysm, the trunks were arising from the sac, and 2 Neuroform stents were deployed in Y configuration. 1-year follow-up angio shows the stable occlusion of the aneurysm. Another difficult MCA aneurysm, trunks were arising with very acute angles from the neck region. In such a case, pre-shaping the microcatheter very much helped the navigation of the difficult branches. In this case, we performed this technique, and the two Atlas stents were deployed in Y configuration. Combination of braided stents with the open cell stents is possible, although we do not perform such a combination commonly at our institution. There are technically important 2 points for stent combinations. First point is the first deployed stent should be an open cell stent. The second point is that any attempt to resheath a braided stent through the strut of an open cell stent may cause the stuck of stent. So we should avoid such resheathing maneuver. This is a basilar tip aneurysm. We deployed an Atlas stent to protect the left PCA. A Leo baby stent was deployed into the right PCA, and the aneurysm was coiled after. Despite the publications of all these papers indicating the safety of Y stenting, there are still two important concerns about Y stenting. One of these concerns is attempt to navigate through a deployed stent may cause the deformation of the first deployed stent. And the second important concern about Y stenting is that there is an intersection point of stents and Y stenting that will be a thromboembolic complication source. And regarding these concerns, T stenting is a good alternative to Y stenting. In T stenting, two stents are deployed into the side branches in such a way that proximal end of one stent faces the side of the other stent, creating a T configuration together. At our department, we usually postpone the full deployment of the stent until sufficient coil mesh is formed inside the aneurysm, preventing the protrusion of the short stent into the aneurysm. Let me share some cases treated with T stenting. This is an ACOM aneurysm with a wide neck, and two Leo baby stents were deployed in T configuration, and the aneurysm was coiled. Post-procedural image show a residual small neck filling, but thanks to the hemodynamic effect of the stents, aneurysm showed a progressive thrombosis at the follow-up, and this 2-year follow-up shows the complete occlusion of the aneurysm. Let me remind you that T stenting necessitates the precise deployment of two stents at the neck region. Especially precision during the deployment of the shorter stent is very important. And to achieve this precise deployment for the short catheter, for the short stent, stent delivery catheter distal marker should be at the origin of the side branches, and the stent marker should be at just 1 millimeter behind the distal marker. So at this final position, a gentle pushing maneuver to the stent delivery wire will achieve a precise deployment. We conducted a multi-center study to investigate the long-term outcomes of the patients treated with T stenting. 102 aneurysms were included in this study, and in this study, 90% of the aneurysms were totally occluded at the final angio. Complications developed in these patients caused mortality in 1% and the morbidity, permanent morbidity in 2% of the case. In summary, result of this study demonstrated that T stenting is effective, durable, and relatively safe technique for the treatment of bifurcation aneurysms. Some cases treated with T stenting, this case was a complex MCA aneurysm. Both MCA trunks were catheterized and a coil catheter was jailed inside the aneurysm. And two Leo baby stents partially deployed to seal the neck of the aneurysm, and the coiling was started. And non-subtracted angio images show the final position of the catheters just before the full deployment of the stents. As you notice, the distal marker of the stent delivery catheter for shorter stent is a little bit located proximally than it should have been for a precise deployment. And to overcome this error, we had to push the stent inside the side branches to prevent the protrusion of the stent proximal and into the M1 segment. And let me share the video with you. Now, we opened the short stent, and as you noticed, the proximal end of the short stent is protruding into the M1 segment, and now we are trying to push the short stent into the lower trunk to get a precise position. And we are pushing with the microcatheter together with the wire. Yes, we achieved a better proximal ending. Yes, final maneuver. The wire is free now. We are taking it out. We are taking the delivery wire out. While this, we're pushing the longer stent to prevent any protrusion. And after we get free the wire, we fully deploy the longer stent into the M1 segment. And now, on the right side, you see the flat panel CT angio after full deployment of the stents. This illustration demonstrates the steps of T-stenting procedure. And on the right side, lower, you see the 1-year follow-up angio of the case. Another MCA aneurysm, which was treated with T-stenting by using 2 braided Leo baby stents. 2 Leos were deployed into the MCA trunks. Immediate post-procedural angio show a small neck filling. However, on the follow-up angios, due to the hemodynamic effect of the stent, the aneurysm showed a progressive occlusion. This 3-year angio, follow-up angio, showed the complete occlusion of the aneurysm. Another case that was treated with T-stenting, a carotid bifurcation aneurysm, 2 stents deployed in T configuration, and the post-op angio showed the complete occlusion of the aneurysm. Another case with a very complex MCA aneurysm, both MCA tracts were originating from the aneurysm. 2 stents were deployed in T configuration into the side branches. One of the branch was deployed before coiling to protect the side branches, and the difficult branches postponed until a coil mesh was formed to protrusion of the short stent into the aneurysm sac. And the 2-year follow-up angio shows the stable occlusion of the aneurysm. And the last case with T-stenting, a complex ACOM aneurysm, which was treated with T-stenting. Another double stenting technique is the X-type stenting. We do not perform intersecting type X stenting because it causes frequent and severe thromboembolic and technical complications. At our department, we rarely perform non-intersecting type of X stenting. And also our indication of X stenting is very limited. It may be performed to coil the ACOM aneurysm, having a special type of neck morphology. In our indication, the angles between the ipsilateral A2 and the A1 segments of the anterior cerebral arteries should be very acute, and the diameter of the ACOM should be large enough to accommodate two stents deployed side by side. As in these cases, a wide neck ACOM aneurysm angles between the A2 and A1 segments were very acute. We catheterized the A2 segments coming from the contralateral A1, and 2 Leo baby stents were simultaneously deployed in X configuration to seal the neck of the aneurysm. And you see the control images showing the simultaneous deployment of 2 braided stents. And after the full deployment of the stents, sealing the neck of the aneurysm, through the J-LUT catheter, we coiled the aneurysm. And As you noticed, there was also small carotid aneurysm. We deployed a very short flow diverter stent to treat this aneurysm, and 3-year follow-up angio shows the complete occlusion, stable occlusion of the aneurysms. Parallel stenting is another double stenting configuration that we very rarely perform to treat very small ACOM aneurysm that do not permit a stable catheterization. In parallel stenting, 2 stents are deployed into the ipsilateral anterior cerebral arteries in parallel to seal the anterior communicating artery. This patient was referred after Lapel surgery following subarachnoid hemorrhage. We put a coiling catheter just at the neck of the aneurysm, and we deployed 2 Leo stents in parallel into the ipsilateral anterior cerebral artery, sealing the ACOM for coiling, and we coiled the aneurysm. And then there is an important point for parallel stenting that we have to check the perforator origin with using flat panel CT angio before coiling procedure. In another endovascular technique, combining the stent assisted with balloon remodeling has been recently described to treat complex bifurcation aneurysm. In this technique, a single stent is implanted into one of the side branches, and the other side branches was protected by temporary inflation of a balloon catheter during the coiling. Therefore, this technique obviates the need for implantation of a second stent during the coiling of a wide neck bifurcation aneurysm. We call this technique stent plus balloon-assisted coiling technique. And we recently conducted a multi-center retrospective study to investigate the efficacy and the durability of this technique, and the results of this study demonstrated that stent plus balloon-assisted coiling technique is an effective and durable alternative for complex bifurcation aneurysms. An example treated with this technique, this patient had multiple intracranial aneurysm. We treated the basilar bifurcation aneurysm by using this technique. And both the PCA and left superior cerebellar artery were originating from the sac. Right PCA was catheterized by a septal balloon, and left PCA was catheterized by a headway Harden Vasco 10 microcatheter, and we jailed a headway inside the aneurysm. We deployed partially a Leo baby stent extending from the left PCA into basilar to seal half of the neck, and the right side of the neck was protected by the inflations of the septal balloon. The aneurysm was coiled by protection of septal balloon and the Leo stent. And after the coiling was finished, we fully deployed the Leo stent. And we also treated a small aneurysm located on the origin of the right PC. We deployed a very short Leo, second Leo through the septal balloon, and we coiled this aneurysm also. Post-op angios and the 1-year follow-up showed the stable occlusion of the aneurysm. And the last case treated with this technique. In this case, there were 2 aneurysms located side by side, and the proximal one was located at the bifurcation. We protected the M1 segment of the MCA by deploying a neuroform stent into the M1, and we coiled the distal aneurysm, and then we coiled the proximal aneurysm by the protection of a septal balloon located in the superior trunk of the MCA. And while coiling this aneurysm, the M1 segment of the MCA was protected by the neuroform Atlas stent. In summary, despite the recent developments of new devices for bifurcation, double stenting techniques remain the eligible endovascular methods to treat complex bifurcation aneurysms. And why stenting with using low-profile open cell stents is effective and safe method. And T-stenting is a good alternative to a wire stenting procedure. It's effective and durable. And lastly, if we need to avoid double stenting, stent plus balloon assisted coiling is a feasible technique in appropriate anatomies. Thank you. Thank you for attention. Hi.
Hi, Kubilay. Thanks very much for agreeing to talk. A great talk. Again, loads of great cases. I think we've got a couple of questions. Yeah. So first one, relatively straightforward for you. For braided stent deployment, do we need to push the stent wire or the microcatheter?
Yeah, the pushing the stent delivery wire is generally adequate. I mean, it's sufficient. But sometimes if we want to compress the stent over the neck to increase the metal density, we push microcatheter over the stent to increase the metal density.
Yeah. Do you often tend to do that at the neck of? Do you tend to compress the flow the braided stents at the neck?
Yeah. We generally compress the stent over the neck to decrease the recurrence risk.
Okay. Another question: can we use one flow diverter in T-stenting?
Yeah, I heard about. I mean, I read one paper. I think you perform it.
Yeah.
But I didn't try. Yes.
No, that's fine. Yeah, so I came up with that technique, but my colleague Levan, who has done it a couple of times, I think the issue with using a flow diverter, I suggest using the flow diverter in the short arm because then you prevent crossing the bifurcation with the flow diverter, which I think you don't like to perform. And as Mani's mentioned earlier, he doesn't like to perform because we're not really sure of the long-term results of putting flow diverters across bifurcations at the moment. Seems to be a little bit hit and miss sometimes. But the problem, as I think you've sort of very nicely explained your technique for perfect landing with the flow diverters, you often do see quite a lot of foreshortening. So landing that flow diverter in the short arm can be very, very, very difficult. Actually, it can foreshorten a lot. Any other last points, Professor Raidan?
No, we listened wonderful speech this morning. It seems that you conducted a great online conference, and I thank you, especially you, for inviting me. It is a pleasure for me to be here.
It's a pleasure. It's a pleasure to interact with you in real terms rather than on the Neuro Addicts group.
Yes.
Okay. All right, lovely. Thanks very much, and hopefully we'll hear more from you later. Thanks. Okay, I think now there will be a very short break. Just to remind everybody that they have to click the agenda to view the next session. Next session will be a bit more on flow diverters, intrasaccular, intraluminal, and then some of the more interesting things around the newer devices as well, and covered stents. Okay, see you soon.